Good afternoon, everybody, and let me all take this opportunity to once again welcome you to the National Combined Grand Round on COVID-19 being done regularly now by the All India Institute of Medical Sciences, New Delhi. And we've discussed many topics, and this time the focus is basically on the management of COVID-19 sequelae. As we've moved forward through the pandemic, and we've now been more than 6-7 months into the pandemic in various parts of the world, we've realized that there is a lot of challenges happening after people have recovered from COVID-19. As a matter of fact, if you look at some data, it has varied from something like 60 to 80% of individuals who recover may have some post-COVID sequelae. It could be mild in the form of fatigue, body aches, but it can also be very serious in the form of individuals requiring to be on long-term oxygen therapy. We've had 2 individuals who've had extensive lung fibrosis and are being advised lung transplant. One person in India has already had a lung transplant. And we've had people who have significant cardiac abnormalities. We've had individuals who've had stroke because of COVID-19, and that has led to significant degree of impairment in quality of life. So I think it's important for us to really prepare for what we call as the next phase in the management of the COVID-19 pandemic. And some people have sort of said this is phase 3 because we also need to look at what we call the post-ICU syndrome that some people have after being in the ICU. Another important aspect which has emerged both because of the pandemic but also because of the lockdown and the whole issue of physical distancing and communicating through technology rather than physically is the strain on mental health. And mental health issues have also become something which have affected not only those who have had COVID, but even sometimes the normal individuals who are sort of at home. It could be students, it could be people of the older age group who've been now sort of confined to a small space and been communicating only through technology rather than physically. So this has also caused a lot of mental health issues. And therefore, we thought it would be very important to have a combined round or grand round on discussing the management of COVID-19 sequelae. And I must say that I'm very happy to have a very good panel to really take up your questions once we have the case discussion and the topic discussion. And I have with me on my left Dr. Ambuj Roy, who's Professor of Cardiology at the All India Institute of Medical Sciences, and I welcome him. I have Dr. Anant Mohan, who's Professor and Head Department of Pulmonary Critical Care and Sleep Medicine at the All India Institute of Medical Sciences, and it's great to have him here with us. We also have from the US someone whom I know very well and who's been part of our regular pulmonary conferences, and that is Dr. Mangala Narasimhan. She's Professor of Medicine, Dolan and Barbara Zucker School of Medicine at Hofstra, Northwell, USA. Welcome, Mangala, and it's nice to see you and have you on board. I still remember your early days messages when the US was going through the peak in New York was going through the peak in the COVID pandemic, and we were still following you. So it's nice to have you on board. We also have Dr. Pratima Murthy, Professor and Head of Psychiatry from AIIMS Bangalore, who will be discussing and taking questions on the mental health issues. I also have Dr. Saurabh Mittal, who's an Assistant Professor in the Department of Pulmonary Critical Care and Sleep Medicine at the All India Institute of Medical Sciences. Saurabh will be presenting an interesting series of cases whom we had seen at the All India Institute of Medical Sciences with post-COVID sequelae. We'll, after that, have a few questions on the cases itself, and then we will have a presentation on management of COVID-19 sequelae by Professor Anant Mohan. And then we'll take up all your questions that you will be sending to us through WhatsApp. And without wasting much time, I'll ask Saurabh to really start off with his presentation on the residual and recurrent effects of COVID-19. Dr. Saurabh Mittal. Thanks.
Good afternoon. We will be discussing 3 important cases with varied presentation after COVID-19. So our first patient, he was a 64-year-old male. He was a non-smoker without any previous comorbidities. He presented in June with fever and sore throat for last 3 days, and for 1 day he had dry cough and shortness of breath. On 4th of June 2020, he was diagnosed to have SARS-CoV-2 positive, and at that time he presented to an outside hospital. At that time his room air saturation was 79%. The chest X-ray which was performed in outside hospital is shown here, which shows bilateral fluffy shadows consistent with the diagnosis of COVID-19. So initially the patient was treated outside. He required oxygen supplementation along with awake proning. He also received steroid therapy in form of methylprednisolone 40 mg twice daily. He received hydroxychloroquine, vitamin C, and subcutaneous LMWH in form of enoxaparin once daily. After 2 weeks of therapy, patient had improvement, and then he was discharged from the hospital. At the time of discharge, patient had symptoms of dyspnea on exertion. His respiratory rate was 22 per minute. His room air saturation was still low, that is 84%, and due to this, he was discharged on home oxygen therapy. At the time of discharge, patient was requiring 2 liters per minute oxygen to maintain a saturation of 95%. 2 weeks after the discharge, once on follow-up, patient continued to have persistent shortness of breath, and he desaturated on minimal exertion like going to washroom at his home. And because of this desaturation and oxygen requirement, he was dependent for activities of daily living. At this point of time, patient presented to AIIMS. At AIIMS Delhi, patient was admitted on 18th July 2020. At the time of admission, patient had generalized weakness. His heart rate was 108 per minute. Respiratory rate was 26 per minute. Room air saturation was low, that is 81%. In the emergency, the DVT screening was done, which was negative, and he had no signs to suggest an infection, and his total leukocyte count was 8500 cells per microliter. So at the time of admission, this was the chest X-ray performed in our hospital. If we compare it with the baseline chest X-ray which was done at the diagnosis of illness in June 2020, we can see though the lung fields have cleared, but what is striking here, that the lung volumes have reduced. If you see, the area of lung has gone down, both sides of diaphragm have gone up, suggesting some degree of volume loss on both sides. This patient, because he had persistent hypoxemia, he underwent a CT pulmonary angiogram with a CT thorax. CT pulmonary angiogram did not reveal any embolism, but what we did find was that he had bilateral GGO with indications of early fibrosis. If you can see from top to bottom, these are the upper cuts, middle cuts, and the lower cuts. The entire lung has got early fibrosis and interlobular and intralobular septal thickening. So this patient, at this point of time, we diagnosed him with post-COVID pulmonary fibrosis because it was almost after 5 weeks of his onset of his illness. He was initiated on prednisolone, that was 0.5 milligram per kg of body weight. As at this point of time, we had no idea what to do for patients with post-COVID fibrosis. The option of antifibrotics was also discussed with the family. Keeping the elderly age of the patient and the side effects associated, the family chose for not opting for antifibrotic therapy because of the side effect profile. And the patient was discharged on oxygen therapy. The last follow-up was 1 week back. At that point of time, patient reported that he was symptomatically better. His room air saturation still was low, 86 to 87%. He was requiring oxygen therapy. At this point of time, we reduced the steroid dose by 10 milligram after 2 weeks follow-up. What is our plan in future for this patient is that we plan to gradually taper the steroids, but how much steroids and for how long we have to give it, that remains still a question. We plan to perform a lung function assessment at his follow-up, and then we plan to enroll the patient in pulmonary rehabilitation program once he comes for follow-up. So this was our first patient, and what we learned in this patient was that post-COVID pulmonary fibrosis is a common condition which is still not clear how to treat this condition and how to identify early. But high index of suspicion in patients who have persistent symptoms is the key to diagnosis of pulmonary fibrosis, and then we can discuss how to treat these patients. Now I go to the second case. It's another interesting patient. He was a 43-year-old male who had presented with fever, which was high grade for 1 day, shortness of breath for 1 day, and on July 6, 2020, he was diagnosed to have SARS-CoV-2, that is COVID-19 illness. At the time of his illness, his room air saturation was 78%. He was admitted in an outside hospital where he underwent chest radiograph, which is shown here, which shows bilateral peripheral consolidation consistent with COVID-19. He required oxygen supplementation, but because of high oxygen requirement and tachypnea, he was initiated on non-invasive ventilation on day 3. At this point of time, patient was not given any steroids, and enoxaparin once daily was started at this point of time. So this was the CT scan which was done at that point of time, which shows that patient has bilateral multiple areas of ground glass opacities, which was consistent with COREDS 5, that is with the COVID-19 illness. So at this, patient was being treated in outside hospital, and he was oxygen requiring, which was very high, and he was requiring around 10 liters of oxygen to maintain a saturation of 93 to 94%. After around 9 days of illness, his repeat RT-PCR was negative, and he was shifted to a non-COVID area. At this point of time, once patient was seen in a non-COVID area, he was initiated on dexamethasone 8 mg 12 hourly, enoxaparin 40 mg 12 hourly, along with the supportive care. So this was the point, that is in the late second stage of illness, patient was initiated on steroid therapy and therapeutic dose of anticoagulation. Over next 5-7 days, his oxygen requirement reduced to 2 to 3 liters per minute, but he continued to have shortness of breath. Gradually, the patient was still hospitalized because he was requiring oxygen into form of 2 to 3 liters per liter of oxygen. His anticoagulation was being continued, but into 4 weeks of his illness, he started having fever along with cough and expectoration. At this point of time, patient's leukocyte count was 24,000 with neutrophilia, and he had evidence of increased procalcitonin. This was the CT chest which was performed at this point of time, which shows that the areas which were initially ground glass now had started showing some evidence of fibrosis in lower lobe as well as in upper lobe, and there was an area of consolidation in the right upper lobe. Sputum examination at this point of time showed carbapenemase producing MTR Enterobacter species, and patient was treated with colistin and co-trimoxazole for the same. But after 2 weeks of therapy, his sputum culture was sterile, but patient continued to have shortness of breath on rest as well as on exertion. At this point of time, his D-dimer levels were retested, which was found to be highly elevated. After 6 weeks of illness, patient underwent a CT pulmonary angiogram. This was a second CT pulmonary angiogram. The initial CT pulmonary angiogram was negative, but after 6 weeks, this was the CT pulmonary angiogram, which showed that there were multiple subsegmental emboli. So at this point of time, patient was diagnosed with having multiple subsegmental pulmonary embolism. At this, patient was continuing to be on low molecular weight heparin, which was on twice daily doses, and patient was started on antifibrotics from outside, that is the tablet pirfenidone 1200 milligrams per day, 400 milligrams thrice daily, and patient was referred to AIIMS for expert opinion. Once patient presented to AIIMS, he was conscious, hemodynamically stable, his room air saturation was 86%. So we continued him on subcutaneous low molecular weight heparin, and over next 10 days during the hospital stay, his room air saturation improved to 92%. This was the chest X-ray at admission, which shows bilateral peripheral fibrotic opacities with some degree of consolidation in the right upper lobe. And at the time of discharge, this was the patient's chest radiograph, which shows bilateral fibrotic and decrease in the lung volume. So thus we reached the final diagnosis of a recent COVID-19 pneumonia with a secondary bacterial infection with Enterobacter species. Then patient had post-COVID sequelae in form of pulmonary fibrosis, and in 6 weeks of illness, patient has subsegmental pulmonary thromboembolism. We discharged this patient on rivaroxaban in form of anticoagulation as well as on pirfenidone. This patient himself was a doctor and was very much distressed about the ongoing pulmonary fibrosis, and he's opted for that I would like to go on the treatment with antifibrotics. So what we learn from this patient is that the secondary bacterial infections are common in patients with COVID-19, specifically the ones who are hospitalized. And patients who are hospitalized and requiring oxygen, the pulmonary embolism should continue to remain a differential diagnosis because these patients have a restricted mobility. So now we go see our third patient. He was a 45-year-old male, non-smoker, without any previous comorbidities. He had history of throat pain with fever, but had no respiratory complaints. His room air saturation was 96 to 97%, and patient was diagnosed to have SARS-CoV-2 positive on 1st August 2020. As he was having no respiratory complaints and his room air saturation was maintained, patient remained in home isolation for 2 weeks and he was asymptomatic during the entire period. On 15th day of illness, patient had to travel by flight for 2 hours, and he, after 8 hours of his travel, he developed high-grade fever, chest heaviness, and shortness of breath. At this point of time, his room air saturation was found to be 82%. As patient was near a health facility, he was started on oxygen by face mask and he was shifted to AIIMS Delhi. At presentation to us, his heart rate was 70 per minute. He was febrile at admission. The chest radiograph which was performed showed bilateral CP angle blunting. Ultrasound chest showed minimal effusion predominantly on the left side. DVT screen was negative. His ECG as well as echocardiogram at presentation were normal. So as patient presented with hypoxemia, he was initiated on oxygen by face mask and he required around 4 to 5 liters of oxygen. Because patient presented in 3rd week of his illness, are diagnosed with high-grade fever, our initial suspicion was of a cytokine storm, and we started the patient immediately on steroid therapy in the form of methylprednisolone 40 milligrams twice daily. Patient had a history of travel, flight, so we started him on LMWH twice daily along with broad spectrum antibiotic. But to our surprise, his inflammatory markers were normal. When we got the reports for IL-6 levels, LDH and CRP, all were normal and ferritin was high. His admitting hemogram showed a hemoglobin of 15.6 gram %. His TLC was normal and platelets were 1,45,000. Although at admission he had some degree of LFT abnormality in form of mild transaminitis, which were around 3 times normal. So this was the CT which was done at admission because we had a suspicion of cytokine storm as well as for a pulmonary embolism. We went ahead with the CT pulmonary angiogram. CT pulmonary angiogram did not show any embolism, but what we found was some degree of patchy fibrosis in right lower lobe which was with subpleural sparing and some atelectatic bend in the lower lobes. But otherwise most of the lung fields were clear. So we were still not clear what was the cause of patient's current illness as his HRCT did not show any significant ground glass. On day 2, the TLC reduced to 3300. His IL-6 D-dimer as well as CRP were normal. We continued the patient on steroids and low molecular weight heparin. He improved symptomatically and oxygen requirement reduced to 2 liters per minute. We continued to monitor the patient in hospital. On day 3, his heart rate reduced to 42 per minute. A 12-lead ECG showed sinus bradycardia and TLC further reduced to 2900 cells. At this point of time, on day 3 of his illness, his platelet count fell down to 70,000 cells and SGOT and SGPT both increased to 405 and 413. So at this point of time, patient was having cytopenias along with LFT abnormalities. So on day 4, we got the report of dengue NS1 antigen and patient was found to be dengue positive. His platelet counts further reduced to 30,000. We had to withhold the LMWH as well as the steroids. And over next 4 days, he gradually improved. His platelet counts recovered, his TLC recovered, his heart rate also recovered. And then he was discharged on room air. On last follow-up, patient has been doing well. So what we learned from this patient was that recurrence of fever after recovery from COVID, we have to look for alternate etiologies as well. Like in this patient who had a travel after the COVID illness, we had a suspicion of cytokine storm versus embolism, and we also looked for the tropical infections and we found dengue. And once patients who have low platelet count, the use of enoxaparin can be very challenging, and we have to reach a correct diagnosis for a successful outcome. Thank you.
Thank you very much, Saurabh, for very three interesting cases. One case, of course, is a classical case of post-COVID fibrosis that we tend to see. The other is another interesting case who came subsequently, had secondary bacterial infection, which we are seeing now because at times we tend to give very aggressive steroids and drugs for cytokine storm, anti-IL-6 drugs. And the third case actually highlights the fact that you may have a person who's recovered from COVID, and if he presents again with fever, don't forget the common causes, especially in our country at this point in time when dengue, malaria, chikungunya are also seen, and these patients could present with infection because of this, of vector-borne diseases. So before we go on to the discussion, just one question I would like to ask both the panelists. First to Dr. Anant Mohan. How common do you think we are seeing post-COVID fibrosis? It's something which has become a big cause of concern among pulmonologists. So how common do you think this is going to be, and is it going to be a major issue in many of our ILD clinics that we run in terms of managing these patients in a large number?
Yes, sir. That's correct, sir. We are seeing more and more of these cases. At this point of time, it would be difficult to give an exact incidence or prevalence number, but as the number of cases and the length of follow-up increases, we are definitely going to see more cases of fibrosis. We already have seen a couple of several, almost up to a dozen or even more. And given the absolute volume of the number of COVID cases, even if it is a small percentage, the absolute numbers of interstitial fibrosis is also likely to be very huge. And one thing is there which we have seen that the fibrosis, whatever is available, the degree of fibrosis does correlate a bit to the severity of illness. So moderate or critical illness probably are more likely to go into the fibrotic stage, although it is too early to be very sure about that, but that seems to be the initial trend, and we do expect to see more of these.
Thank you. I think this is something that we will have to see with time as to how common is post-COVID fibrosis in terms of its, let's say, incidence and prevalence. But I think also the important issue is what are the risk factors for developing post-COVID fibrosis, and secondly, how do we assess them? Because over time, some patients do show improvement in their fibrosis and the oxygen requirement, whereas others actually really don't show any improvement. So how do we segregate these two segments? One question for Ambuj in terms of the cardiac involvement. How common do you think that is? We've seen a few patients, but it's another cause of concern. And what is the common cardiac sequelae that we tend to see as far as these patients are concerned?
Once the patient recovers after COVID, we really cannot lower our guards, because it's been clearly seen that after severe pneumonias, and there's data from SARS and MERS, that patient after a severe pneumonia are typically prone to cardiovascular events, because this is an inflammatory state, and so is atherosclerotic cardiovascular disease, and these cytokines can precipitate the inflammatory cells in the plaques which are there, for example, in the coronary arteries, and lead to their vulnerability. And they've been shown that actually after severe pneumonia, your chance of having cardiovascular events like heart attacks are raised up to the tune of 6 times, especially in patients who are vulnerable, that is those who have multiple risk factors, or those who already have heart disease, or those who have multiple risk factors like elderly, those with diabetes, hypertension, dyslipidemia. So, so my point is that we should be follow these up patients very diligently. If they were on their cardioprotective medicines, they have to be continued, like aspirins, statins, other cardioprotective drugs like RAS inhibitors or beta blockers as merited for the patient. And if they are on them, we need to continue them. If they were not on them and they merit to get these medicines, we need to give them that very religiously, so that they don't land up with cardiovascular events, which is very well known to happen in these patients post severe pneumonia.
Thank you very much. I think before we go in to all the questions which have come through the WhatsApp and through other means, we will have a detailed discussion which I'll ask Dr. Anant Mohan to give on an overview of the literature as far as management of COVID-19 sequelae is concerned. I think many of the questions which have come up could be partially or to some extent answered by this talk. So let's have the talk and then we will take up questions after that. So Dr. Anant Mohan for the talk on management of COVID-19 sequelae.
Okay, thank you. And so I'll be giving a brief overview of whatever we know regarding the COVID-19 sequelae and whatever we know regarding how to manage them, taking into account the fact that we're still about very early days yet as far as sequelae is concerned. But whatever we know, probably we'll see how one can manage those things. So it's an unknown journey, and we really do not know much about the long-term outcomes of patients who have recovered and then those who come back to us after other complications. But one thing we do know, and as you have seen over the last several months, you would have seen that COVID-19 does appear to be a multi-system kind of a disorder. It can affect almost every organ. Several major organs have been implicated, and if we see the summary over here in this slide, we can see that it involves all aspects of medical care. It can affect the eyes by causing impairment of retinal vascularization. The effect on the nose is well known, and we know that it has it causes problems of smell and also problems of taste. Nasal obstructions may occur. The cardiac problems are also well known, and we'll be talking about that, causing inflammation, myocarditis, pericarditis, congestive cardiac failure, which may be acute on chronic most of the time. Then effect on the kidneys are well known, especially in the severe patients. In the cytokine storm, there may be acute renal shutdown has been noted. Then hypervascular kind of symptoms are there, hypervascularity leading to blood vessel involvement in the form of blood clots, endothelial dysfunction, thereby leading to strokes and other vascular problems. Then of course we know that it's again inflammatory state, and also the increase of inflammation related cytokines is well known also, and autoantibody production is also known to occur, and probably it has some role to play in aggravation of rheumatological disorders. As far as the muscle is concerned, definitely there is immobilization among the hospitalized patients, and that leads to further problems of sarcopenia, malnutrition and long-term disability, or rather subacute disability rather I should say. It has a predilection for the gut and can infect the lower GI tract. One of the presentations of COVID, in fact, is as diarrhea, and that we know. It also may lead to some level of liver dysfunction by means of increasing the liver enzymes because of the direct action of the virus. And lungs, of course, remain the predominant organ which is involved, and we all know the symptoms and the radiological features of that. There are also effects on the brain, and that can be in the form of neurological or in the form of psychiatric symptoms, and we'll see a little bit about those as well. So if we see the magnitude of the problem is the post-COVID persistent problem. So although again we don't know much, but there are one or two studies which have looked into this, and if we see this particular study in which patients were assessed over a mean time of around 2 months after the first symptom, out of which it was found that only around 12.6% of the patients were actually completely free of any COVID symptom. Almost 1/3 had at least 1 to 2 symptoms, and almost half of them had 3 or more symptoms. And if we see on this side, on this diagram, what were the symptoms, you see that the most common symptoms which persisted were fatigue, dyspnea, joint pain and chest pain. So they were mostly the non-specific type of the symptoms which were there, the myalgias, the musculoskeletal problems, something which is there which we have all experienced because viral fevers are known to cause a lot of myalgia. So these are the symptoms which were seen in more than 20% of the patients even after 2 months of recovery from the first symptom. And there are several others like cough, anosmia, sicca, rhinitis. So all other symptoms are also there to some extent. Many of them also persisted. Of course, none of them had any acute symptoms, but there were worsening. All these led to worsened quality of life in almost 44% of the patients. If we come to the organ-wise per se, the pulmonary function assessment, because the lung is the main organ which is targeted, so it is natural that we think of the sequelae on the lungs as the first priority. So this was a small series of 77 patients, out of which 22 were excluded. They looked at 55 patients, and this was the breakup of mild, moderate and severe pneumonia among them. What they did was they divided these patients into two groups based on the CT score. These were the normal CT ones, these were the abnormal CT. And then they did the pulmonary functions, and as we can see, out of 16 patients with normal CT, 2 had abnormal pulmonary functions, whereas out of 39 patients who had abnormal CT, almost 1/3 of them had abnormal pulmonary function, thereby meaning that if there is severity of disease based on a CT scan, then we can actually think probably they are likely to have more chances of abnormal lung function on a follow-up. And that is what they did. When they looked at the PFT abnormalities, overall was seen in around 1/4 of the patients, and this was the commonest one. The commonest abnormality was decrease in the diffusion capacity of carbon monoxide, followed by impairment of the small airway functions in around 12%, lowered FEV1 and FVC in 10 to 11%, and total lung capacity was also lower in a small minority of the patients. But so this just goes to show that almost 1/4 of patients had some degree of pulmonary function abnormality, and it is of a varying degree. The most common was DLCO impairment. As far as the radiology is concerned, and these are some radiographs at symptom onset and then something residual. As you can see, the ground glass features over here on both the sides, and this is following that becoming more and more denser as the disease progresses. Then with recovery, it becomes lighter and there is mild resolution, and over here there are only some residual parenchymal bands and a little bit of GGO seen as the recovery is progressed. So recovery also occurs, but it takes some time, and we shall see later what is the time duration over which a recovery may take place. Another figure which has been taken to look at the GGO, this is a mild ground glass GGO on the left lower lobe, and over here you can see this is a mild one over here, and 3 weeks later, as you can see from here, it has become much more fibrotic, it has become bilateral, denser. So fibrotic changes just like was shown in the case a couple of minutes back. And even in the lower lobe, you can see the dense fibrotic changes have started to appear. So these are the ones which are the pulmonary sequelae which are likely to cause problems later on, and probably the need for oxygen as well. What are the risk factors for pulmonary fibrosis following a COVID-19 infection? Although again, we don't have much, but most of the data has been extrapolated from idiopathic pulmonary fibrosis, and as we can see, there are many things in common between that and this, and also the some data has been extrapolated between the available information from the SARS and the MERS, the epidemic which came about a couple of years back. So older age group, more severe illness, longer length of ICU stay, the need of mechanical ventilation, smoking and chronic alcoholism are some of the factors which probably are related to as risk factors for development of future pulmonary fibrosis. So how can we reduce the risk of pulmonary fibrosis? Again, these are extrapolations. One, most of the patients are likely to be on oxygen or even on a ventilator in the ICU. We have to minimize the risk of ventilator-induced lung injury by using the protective lung ventilation settings, low tidal volumes and the low inspiratory pressures. Patients should be well educated on limiting the exposure to any environmental factors which may increase the lung injury, stop the smoking, and a good and a regular follow-up using various lung function tests, including spirometry, 6-minute walk test, saturation monitoring, and wherever required, a radiological scans should be done. The role of antifibrotics is now coming more and more, and the questions are coming as to their role in pulmonary fibrosis. Again, most of the data is extrapolation of other epidemics related coronavirus. We have two main antifibrotics available, pirfenidone and nintedanib. As far as the mechanism of action is concerned, pirfenidone inhibits cytokines, TNF alpha and IL-1, that is anti-inflammatory, and by that it inhibits proliferation of the fibroblast, inhibits inflammation, and thereby also inhibits the fibrosis. Whereas nintedanib inhibits the vascular epidermal growth factor, the fibrotic growth factors, platelet-derived growth factor inhibitor. All these are the mechanisms of nintedanib, but always it is advocated to use them in combination with anti-inflammatory agents as far as the current literature is concerned. Then, as already mentioned, another important thing is that lung transplant for post-COVID fibrosis is an option, but again, probably only meant for patients with extensive severe fibrosis and respiratory failure. However, most patients are likely to have comorbidities and many other secondary complications related to sarcopenia, renal dysfunction, and that may preclude them from being good transplant candidates. Hence, transplant should only be considered in a very select group of patients who have COVID-related ARDS or extensive fibrosis. And ultimately, the ultimate effect and results of this the life-saving therapy in this current population still remains unknown, and we don't really have much to tell as of now. Although some procedures have been done, and one in India as well, where in Chennai the doctors performed Asia's first lung transplant on a COVID survivor. So early days yet, but maybe in a small select group of population, this may be a good option. Some common questions which come about now are among the patients and as well as in the medical fraternity are when to do the radiological scans. So what is the radiological course of COVID pneumonia? When should we do a follow-up imaging? What is the sequelae of this? Is the fibrosis going to be permanent or is it going to resolve? So all these things are there. Again, I was able to pick up one retrospective review of CT scans that were performed, one at the time of discharge, and then after 2 weeks, and then after 4 weeks after discharge. And what it was found was that over a period of time, the focal GGOs reduced from 17 to 9%. The multiple GGOs also reduced quite markedly. Consolidation decreased. Interlobular septal thickening also decreased. So basically all abnormalities, including subpleural lines and the other irregular lines, they all reduced over a period of time, over the period of 4 weeks actually in this particular study. The lung lesions which were there in around 1/4 of the patients also were almost completely resolved in the first CT after discharge. The rate of lung recovery increased to almost 65% after the second follow-up, thereby meaning that gradually over a period of time, most of the lesions, they improve, although it takes time. So one should not be in a hurry to kind of repeat the CT scans. So maybe we can conclude that the lung damage due to COVID-19 could definitely be reversible, as we have already seen, although the optimum timing of the follow-up scan is yet to be determined. But probably it is prudent to wait for at least 4 to 6 weeks before one orders or asks for a follow-up radiological scan to ascertain the extent of any residual damage, because these things take some time. Coming on to cardiac manifestation, just a brief word about the cardiac manifestation. The possible mechanisms by which cardiovascular injury occur may be by direct cardiotoxicity of the virus, by means of the hypoxemia that occurs. There may be some supply-demand mismatch of oxygenation and the blood supply to the particular organ, or related to cytokine storm, or maybe as a manifestation of the DIC which occurs. And the various manifestations which may occur in the heart are acute coronary syndrome, arrhythmias, myocarditis, venous thromboembolisms, and sometimes heart failure may be precipitated. And we have had certain cases of sudden cardiac death or cardiogenic shock as well. This was one article that looked at cardiac complications post-COVID, and this looked at 3,000 odd patients over a 1-month follow-up after recovery. And they classified these patients into those who had previous congestive cardiac failure, and there were 152 of them actually. It was found that these patients, they were more likely to develop acute heart failure. They were more likely to have higher levels of NT-proBNP levels. They were more likely to have a higher mortality compared to those who did not have congestive heart failure among the entire group. Out of this whole group, 2.5%, that is 77 patients, developed acute heart failure. And a majority of these patients developed the heart failure in those where no previous heart failure was anytime detected. So it was kind of a de novo kind of a thing. They also found out that arrhythmias and CHF are the main predictors of subsequent development of acute worsening of the cardiac symptoms, and definitely it was associated with a higher mortality. As far as the neurology is concerned, neurological complications are also being recorded more and more, and in another small group of patients of 58 patients who were admitted in the ICU, 14% had some neurological findings, but this was during treatment. At the time of discharge, almost 1/3 of them had some or the other abnormality in the form of inattention, low attention span, disorientation, or poorly organized movements. And 2 of the 13 patients who underwent a brain MRI actually had single acute ischemic strokes as well. And critical illness related encephalopathy has also been reported. So these are some neurological findings which are seen during discharge or subsequently in COVID-19 patients. And if we look at this, the bar diagram, smell disorders, taste disorders are the most commonest which are reported, followed by myalgias and headaches, which are also known to occur. Although one cannot in the strict sense call these to be neurological, but that is how this paper has taken them as. And then there are a host of other manifestations like encephalopathy, ischemic stroke, ischemic intracerebral hemorrhage, and many others like encephalitis, acute myelitis, even Guillain-Barré syndrome, etc., have been reported as part of neurological complications of COVID. And not just the neurological, but there are also psychiatric manifestations, and with a lot of lockdown and other stresses which are coming up, more and more neuropsychiatric sequelae are being seen. The reason that of these can be multifactorial. It may be lockdown psychological stress, it may be because of infection of the to the organs, basically it may be because of the inflammatory cytokines, peripheral inflammations. So basically all the combination of inflammation, hypoxia because of respiratory failure, and other markers may affect the brain to cause any of these neuropsychiatric symptoms like depression, bipolar disorder, post-traumatic disorder, psychosis, epilepsy. So all of these are potential psychiatric manifestations which may actually need to be looked at. And this was a small study which was done at our onco-anesthesia department, palliative care department, in which they looked at basically the stigma which was associated with COVID-19 in the patients who had recovered and were about to go home. And just a brief mention was that definitely you see with all these questionnaires, the self-perceived stigma in quarantine, whether in the neighborhood, experienced by the patient's family, in the marketplace, at work, all of these you can see there is a large proportion of patients who really experience or who feel that there is some amount of stigma associated with this particular disease. So that is something very important and needs to be looked at in the long term. Vascular wise, yes, COVID-19 again predisposes to both venous and arterial thromboembolism, and we have seen a case of pulmonary thrombosis which was just presented. So among 184 ICU patients, the cumulative incidence of all these vascular episodes was almost 31%. These included all PE, DVT, MI, strokes, and systemic arterial embolism. And mind you, these were ICU patients, so they are not like the mild patient, but they are all critical patients. In another small study, pulmonary embolism was the most common thrombotic complication which was detected, but ultrasound and CTPA was able to detect venous thromboembolism in almost 1/4 of the cases as well. So the incidence of thromboembolic phenomenon is also pretty high in this group of patients, especially the serious patients. Again, the question will come, how much to give the prophylaxis, how long to give it. So as of now, routine post-discharge prophylaxis for venous thromboembolism is not recommended. Whatever data we have are again extrapolations from high-risk patients without COVID. So in those group of patients, 2 drugs have been recommended for post-discharge prophylaxis, that is rivaroxaban and the betrixaban. And the high-risk factors are older age, high D-dimer level, and a modified improved thromboembolic score. This improved score is also, we are not going into the details, but this depends upon many factors like age, severity of disease, cancer, immobilization, etc. Based on that, if a score is more than equal to 4, it's a high risk for and a candidate for giving post-discharge prophylaxis. Of course, at our setting, we have to consider all of these individual risk factors like mobility, bleeding risk, and the feasibility for monitoring at home if required. So all of these have to be done. Now, Once a patient has improved, especially if a patient has improved from the intensive care, another entity which is now coming up is known as the post-intensive care syndrome or the PICS. This is something when a person of severe COVID complicated by respiratory failure, multi-organ failure, resulting in ICU with mechanical ventilation, when they recover, this syndrome is defined as a new or worsening cognitive, psychiatric or physical functions after a critical illness. So this is another new entity, and this will be seen more and more, and this requires the rehabilitation, which is mostly in the form of ventilatory support or related to the prolonged immobilization and nutritional support, etc. And what is the rehabilitation that should be given after recovery? Most commonly, the impairments which are likely to occur are physical deconditioning, muscle weakness, fatigue, impaired lung function, delirium, other cognitive impairments, and mood and mental health disorders. So again, a multidisciplinary team approach is very, very essential. This includes physiotherapist, also includes pulmonary rehabilitation. We haven't gone into the detail of that, but breathing exercises, using yoga and other features. And if you have the facility of in-hospital pulmonary rehab, probably it would be a good idea to call the patient at least once or teach them before they go home, and the rest of the rehab can be followed on a kind of a teleconferencing, which is now becoming more and more popular. Another question which we had seen and being asked many times, what is the role of inhaled corticosteroids in these patients? As of now, there is no evidence on benefits or harms of inhaled corticosteroids in COVID-19. Some in vitro studies have indicated that cyclosinide has some antiviral properties, and in 3 patients, some favorable outcome have been presented also. Because inhaled cyclosinide is expected to reduce the viral replication and inflammation, and it has lower immunosuppressive effects. But on the other hand, a single in vitro study of budesonide actually did not observe any significant reduction in the viral replication or inflammatory cytokine. So it is still early days. We really do not know the current status of inhaled corticosteroids in COVID as of now. Finally, again, now we have to follow up the patient. So when to call back the patient, how frequently, and whom not to follow is required for a follow-up. So nowadays, I think telemedicine is a good option to follow up all these patients. Ideally, all of them should be followed up at least initially, and especially the sick patients definitely should be followed up initially at 3 to 4 weeks. Again, these are all experience-based. There is no evidence for this, but as a good clinical practice, at 3 to 4 weeks, probably a first visit can be made, then repeated at 2 to 3 months, and then after 6 months, and then, of course, depending upon the condition. Post-ICU care will require multi-speciality specialty follow-up depending on whichever organ was involved. All that has to be taken into account. Rehabilitation, counseling, nutrition support has to be given. So I'll conclude here by just a couple of points that COVID-19 now appears to be a multi-system disorder. Although the degree of organ involvement, the timing and the severity of organ involvement remains variable, we do not really know the predictive factors of people who are likely to progress or those who are likely to go into sequelae, any kind of sequelae. But we should remember that late manifestations are known to occur and they are common. Hence, a regular multidisciplinary follow-up, probably along with a good protocolized screening protocol, should be in place for early detection of long-term complications to prevent any long-term morbidities as well. Thank you. I would like to acknowledge all the people who were involved, all the patients, all the staff who have been on duty for almost 6 months at a stretch now, and all the departments who were related with this, onco-anesthesia, hospital admission, anesthesia, and all the allied specialties of medicine, and my own department, faculty, and fellows. Thank you.
Thank you very much, Anand, for a very comprehensive coverage of the management of COVID-19 sequelae. Before I ask the questions, I would like to really get on board the 2 panelists that we have, which are there through our web link. And I'll start by asking Dr. Mangala for her comments on how frequently are they seeing these issues of post-COVID-19 sequelae and how they are going about managing these patients in the United States.
Thank you, Dr. Galeria. I'm happy to review by Dr. Moore. We started our big peak was March and April. So we are seeing a lot of post-ICU syndromes. We are seeing a lot of patients who had critical illness polyneuropathy from all the paralytics and sedation that we had. their ability and their muscle wasting is not back to normal yet at all. And that's been a big struggle with functional status. We're seeing a lot of LV dysfunction. Patients are coming back with heart failure symptoms, and a lot of patients who had normal heart function when they left the hospital are coming back now with decreased LV function. I'm not sure exactly why. That's something that we need to look into, but we are seeing quite a bit of that. Obviously, pulmonary fibrosis has been a very common thing. We have a pulmonary fibrosis clinic now post COVID specifically, and we're trying to do pulmonary rehab with these patients and starting them on therapies. A lot of them are on long-term steroid therapy with a little bit of relief, but not significant. If they come back to the hospital, they're presenting with things like secondary bacterial infections, a lot of GI perforations, GI gallbladder symptoms that we're seeing a couple of months out of COVID. Unclear if that's related to the IL-6 medications and prolonged immunosuppression from that. But we are seeing quite a bit of that, and that's an interesting phenomenon as well. We did decide to do post-discharge prophylaxis based again on the scores of IMPROVE and with rivaroxaban, and pulmonary embolism and DVT have become a very common thing in this patient population that have not gone home with that. So we're struggling with that as well. So a lot of reasons to come back to the hospital, a lot of patients who have now become frequent hospital patients because of COVID and its sequelae, and those are the kind of things that we have been seeing.
Thank you very much, Mangla, and I'll come back to you with the questions. Before I do that, I'll just ask Professor Pratima Murthy from NIMHANS to give her comments as far as the issues of mental health is concerned, both in patients who are COVID positive and as a part of post-COVID sequelae.
Thank you very much. Let me just talk about the various phases of the COVID and the psychiatric sequelae with each of these. I think in the beginning, in the pre-COVID time, a lot of the psychological sequelae were around, the fears of getting COVID, a lot of psychological stress that people faced because of the lockdown. There was reports of anxiety and depression that occurred as a consequence. Of course, as a result of the lockdown, there was a lot of stigma as well, especially when people were being tested for COVID and and had to be quarantined. Then there was a lot of anxiety around getting tested, particularly when persons got tested themselves, and when family members also got infected. There was and a lot of issues around stigma. Even when some of the patients were admitted into hospitals, COVID doesn't come with the infection alone. It comes with a whole lot of other social and economic factors that go with it. So, there have been cases of extreme depression as a reaction to being tested as COVID. There have been cases of suicidal attempts and completed suicides as well. So I think the psychological stress that is associated with COVID must not be underestimated in any fashion. Subsequently, in terms of the hospitalization, we've already heard a very nice lecture on the neuropsychiatric sequelae of COVID, and we must understand that just like any other inflammatory disease which affects the central nervous system, the same inflammatory mechanisms can also underlie various mood disorders, even schizophrenia and other psychotic disorders. So it's very important to, although there are no original research on this, when you when you kind of look at the other viral infections that have been there, one can assume that the same kind of problems can also occur, and we could anticipate that there would be depression and post-traumatic stress disorders, obsessive compulsive disorders, and perhaps psychotic disorders as well. The other important thing is persons with mental illness who have COVID. We've actually had some of the patients developing asymptomatic, being positive for COVID, but being asymptomatic, and they've recovered more or less well. But we'll have to look and see in the long term what might happen in terms of the sequelae for them. Sometimes the medications that are used in psychiatry can have important consequences, both in terms of cardiovascular side effects, in terms of their effect on the hemopoietic system, and a lot of caution needs to be taken in the use of psychotropic medication. Similarly, the drugs that are used for the treatment of COVID can also have neuropsychiatric manifestations, particularly steroids or chloroquine. We don't know very much about the newer antivirals like remdesivir, but I think it's important to understand that they may have sequelae as well. Another syndrome that is now being described is the long COVID. I think the previous speaker alluded to that very well, but perhaps the chronic fatigue syndrome and so on, actually a sequelae of from after recovery from the acute manifestations of COVID is something that we need to remember. Another thing that has been described is post-traumatic stress disorder, where people can have a reliving of the experiences of being in hospital with COVID, have nightmares about it, have insomnia. We also know that any stress can also increase the use of substances, both tobacco and alcohol, and these also have important consequences in terms of reducing the immunity and increasing the risk for infection as well as outcome for the infection. And this must also be very important, recognized. And of course, COVID has a lot of other collateral problems as well, because many patients with mental illness and COVID might have non-communicable diseases, might have other sequelae as well. And of course, I haven't alluded to the other neuropsychiatric manifestations in terms of delirium, confusion, seizures, and others. The most important thing, I think, is that people need psychological support at every level. We talked about counseling, telephone counseling, telepsychiatry as a thing. And of course, at each point in time, making sure we don't miss the psychiatric sequelae, which are eminently treatable. And I think providing support to people in all these phases is a very, very important aspect of psychiatric management. I'll stop here.
Thank you very much, Dr. Pratima Murthy, and for giving a very comprehensive coverage and the challenges that we're facing right now as far as the mental health issues in COVID is concerned. We have a whole number of questions that have come through WhatsApp and are still coming in. So I'll start the question session, and I'll start with Mangla, and I'll ask her. And this is basically a question which has actually come in multiple forms. And I'm going to ask both Mangla and Anand as far as the treatment of pulmonary fibrosis is concerned. What is the role of antifibrotics? When to start antifibrotics? So I think a lot of physicians are wanting to know that once you diagnose pulmonary fibrosis in a person who has a post-COVID sequelae, what is your treatment strategy? And is there any difference between giving pirfenidone and nintedanib? So I'll start with you, Mangla. What is your treatment protocol that you follow in patients who have post-COVID pulmonary fibrosis, and then ask Anand to supplement that.
So we are waiting to see how far out from happens. We don't like to give the first.
Mangla, we can't hear you very well. You'll have to.
I'm not sure why.
Yes, now we can hear you. Okay.
Okay, good. We are waiting for at least 2 or 3 months after the initial fit to see what we should start. And if 3 months later they're still having persistent pulmonary fibrosis in the systems and restricted lung disease, decreased CLCO on TSTs, then we are thinking about starting the antifibrotics. Which one we start in the US really?
Anand, if you want to add on to that.
Yeah, so what we are doing is whatever patients come to us with kind of refractory hypoxia, because that is the one who come after recovery, they go home. Either they may go home on oxygen for some time and they don't improve, They come back after say week, 2 week, 3 weeks, oxygen requirement is not falling, so we feel, and then we do a CT scan. So the CT scan in most of our cases is not done upfront. Over here in India, we are not doing baseline CT in most of the patients, but in the refractory hypoxic patients, we do a CT at around say 1 month time or so, 3 to 4 weeks. If that is showing fibrosis and ground glass, we may we then give another course of steroids if it is not already been given. So we give a course of steroids and we see the improvement. If it is not, and if over a period of next 2-3 weeks, and if again the fibrosis is increasing or persistent, then we discuss with the patient the role of antifibrotics. We haven't given it in too many patients as of now. We have only limited experience. We can't compare pirfenidone with nintedanib as of now here because there is no insurance. Patient has to bear the cost. So we discuss and then we start antifibrotics.
Thank you. I think the bottom line here for people who are listening in is something that we would do as a standard protocol is that in the beginning we will give them anti-inflammatory drugs in the form of steroids. And as was mentioned, maybe something like 0.5 milligram per kg of prednisolone, and follow them up for around 3 months. As Dr. Anand Mohan showed, that in many individuals, as a matter of fact, over a period of time, a lot of these shadows resolve and their lung function tend to improve and their oxygen capacity and saturation also tends to come up. But if after 3 to 6 months there is still persisting fibrosis and you find that now this is going like a fibrotic lung disease, then I think there is a role for giving antifibrotics, and you could consider either pirfenidone or nintedanib. Really not in any data to suggest one or over the other. Probably we would prefer pirfenidone because it's more cost effective as of now in India. I don't think upfront on day one or on discharge, or even after 2 weeks of discharge, if you find there are features of fibrosis, one would start giving antifibrotic drugs. So a lot of individuals here have asked that should we start antifibrotic early? I don't think there is enough data. But there's another interesting question which follows from that, and that is basically looking at what we have, the treatment that we have in the, let's say, the IIPs, which are not the IPF, and that is, would we consider giving other immunosuppressants along with steroids? And this is a question that one person has asked, that why can't we give mycophenolate mofetil, azathioprine, or cyclophosphamide along with steroids? Do you think that will make a bigger difference in decreasing the post-COVID fibrosis early as intensive inflammation? So again, maybe this time Anand can answer that, and after that I'll ask Mangala if she has any comments.
Okay, so again, sir, these options are there, and because the questions are coming because we don't know. So we have no experience, and I'm sure the experiences around the world would be also very, very limited on other immunosuppressive agents in addition to steroids for the post-COVID type of fibrosis. As of now, I think it would be better first to give a good course of the anti-inflammatory drugs that is there, because most of these patients will have some kind of indolent ground glass smoldering along. It is possible, so that should be taken care of first. And if there is a definite decline in the lung function, so PFT and all things also have to be done. If there is a definite decline and there is a definite increase in the fibrosis, then one has to take a call on. The only thing is, there are a couple of publications which have said that IPF and COVID-related interstitial fibrosis do have some things in common. So that is why the whole concept of antifibrotics of pirfenidone and nintedanib came into being. And so far, not too much of emphasis has been there on the other immunosuppressive agents. So IPF also comes in more likely the older age group. It is more in the associated with smoking, more associated with alcoholism, immunosuppressive states. The same has been found in the patients of pulmonary fibrosis after COVID as well. So that is why probably there is some link between these two, and that is why antifibrotics of IPF as of now are being kind of tested, if I may put it that way, and not the other immunosuppressants. But maybe these things may change in the future.
Thank you very much. Yeah, Mangala, for your comments.
We're not using any of the upper, either
stop using them for pulmonary fibrosis and haven't picked up using them here. There is definitely thought that this is related to the inflammatory state, as you said, but in the past also with idiopathic pulmonary fibrosis, those drugs have not shown to be that useful. So we have not gone to using those drugs. Long courses of steroids we have tried prior to using nintedanib or pirfenidone, but not the other drugs at this time. I think the patients who respond to the steroids definitely will still have some fibrosis, but will have some better quality of life. The patients who go on to the antifibrotic drugs, which we're not using that often either, are really struggling still 4 months, 5 months later with their ability to do normal functions of daily living. So those are definitely the more severe patients.
Thank you, Mangla. Thank you very much. Now I have two questions for Dr. Ambuj. One is, should we give antiplatelet drugs to these patients on follow-up? If you're talking of thromboembolic complication, is there a role of antiplatelet drugs? And what is the duration of anticoagulants that you would really advise once these patients are discharged?
Yeah, so again, they're very relevant questions, but there are a set of patients who will definitely benefit from antiplatelet. There are patients who already have established cardiovascular disease, and there definitely antiplatelets need to be continued because these patients, as I mentioned earlier, are very much susceptible to have a cardiovascular event post COVID-19 because of the inflammatory state. So these patients definitely need to be on antiplatelets as to the patients who do not have established cardiovascular disease. I would also recommend in them who have high risk for cardiovascular disease, like people who have multiple risk factors, diabetes, hypertension, and elderly who again are susceptible to these diseases. So there again a role of antiplatelet may be there. But other than those patients, I don't think there is enough data to support antiplatelet in all patients of COVID-19. So only patients with established cardiovascular disease and those who are at high risk of cardiovascular disease need to be on aspirin. These patients also need to be on optimum dose of statins and also other cardioprotective drugs as may be needed. As for the anticoagulant, I think Dr. Anand had covered it in his talk. So again, as for all the patients, it's not recommended prolonged anticoagulation, and it's really based on your risk for a VTE event. So that you could judge from multiple risk factors. You could use a score like the improved VTE score, or you could do a D-dimer, and if it's more than two times higher, then there may be a case to put these patients on prolonged anticoagulation. And so it really depends on the risk factors for thromboembolism, like if they're immobilized, if there is cancer, or if there is heart failure, all those things which increase your chance of thromboembolism. So we generally are using the improved VT score and a D-dimer to assess that, but not for everybody anticoagulation.
Thank you very much. I'm now going to ask Saurabh two questions. One question is, does tocilizumab lead to less chance of post-COVID fibrosis? Is there any data on that? And the second question is by a physician who says that why don't we regularly give low-dose steroids at the time of discharge? Will that decrease the chance of pulmonary fibrosis in patients who have COVID-19 infection?
Sir, regarding the first question of tocilizumab leading to low fibrosis, first of all, we have to understand that tocilizumab we use once we have cytokine storm. So there is a risk of higher chances of having infection rather than thinking that it may reduce the fibrosis. So we don't really know the answer to this question because the mechanism of action of tocilizumab versus the steroids is anti-inflammatory agents, but tocilizumab causes more chances of infection. So regarding the fibrosis, we can't predict, and still we don't know the answer to this question, whether tocilizumab can reduce the chances of fibrosis. Steroids we have been using in ILDs for long time, and there has been like non-IPF ILDs, steroids do help. So probably steroids will still continue to be the answer, that whether given in the acute COVID or in the post-COVID time, they may reduce the chances of fibrosis or its progression. Regarding the question that whether we can routinely give low dose steroids, so I'll just tell one patient which we recently got. This patient was discharged around 6 weeks back from another hospital on low dose steroids because she had a oxygen requirement at discharge, and then once she came to us, she had a left upper lobe cavity and she was diagnosed to have sputum positive tuberculosis. So this routine use of steroids is probably not the correct answer, because steroids are not just safe drugs, they can cause side effects also. So it has to be balanced. So patients who have sequelae or who have risk factors to develop sequelae, in those patients selectively we may give steroids, but not routinely. Thank you, sir.
I think that's very important, that you have to look at the risk benefit, and in individuals who are otherwise stable or don't have features of a sequelae, there is really more harm in giving regular low dose steroids or steroids for a long period of time, both in terms of opportunistic infection and also in other side effects that we know can occur because of long-term steroid. There's one question which I'm going to ask Mangla, because this is from a final year MBBS student from Madhya Pradesh. And he says, what is the lowest saturation value and on which a patient should be put on non-invasive ventilation? And can that prevent load on the lung for their healing and development of fibrosis? So any comments on that, Mangla?
So we've been reading a lot about this, debating because there's been a lot of controversy in the US about intubating patients versus non-invasive. There's two theories, I think. One theory is if you put someone on non-invasive and they're really struggling to breathe, their intrathoracic pressure is swinging up and down so much that they're actually taking large tidal volumes and working very hard with a lot of negative pressure, and they are actually causing lung damage and fibrosis by being on non-invasive. The other theory is that you prevent ventilator use, and that is a positive, and you prevent death and other complications from being on a ventilator. So I'm not sure what the right answer is. During our COVID surge in March, we used a lot of ventilation, did not use a lot of non-invasive. We weren't sure about the infection rate from the non-invasive. As we go through our second surges now, we're trying to use more non-invasive. We are seeing that when patients do get intubated after long periods of time, a week or two on non-invasive, that their lung disease is pretty far progressed, and their fibrosis seems to us to be progressing very quickly. So I don't know the right answer to the non-invasive versus the regular ventilator. Unfortunately, even with the thousands of patients we took care of, we were not able to understand which path is a better path. I think that not intubating in patients who are obviously just hypoxemic and are not working very hard makes a lot of sense. I think if patients are really struggling on non-invasive, then that may be a reason to go ahead and intubate. And on the point that we were making on steroids, we've seen a lot of strongyloides infections as well. We have a lot of patients from the Caribbean, from islands who have endemic strongyloides in their country, and they're coming here getting steroids for this. And we've seen a lot of patients who have developed strongyloides as well. So something to keep in mind with the use of steroids. But non-invasive is a very tough topic. I don't have a good answer yet. I'm hoping you guys will tell me.
Basically asking how should we assess our patients on discharge to look for any associated stress or anxiety that this may have. This is basically from people who are not in psychologist or in psychiatry, but are internist, who would want to know that should they do some assessment, and what assessment should they do when they send their patients home, to really get an idea if they have some sort of need for the post-COVID stress.
So I think the assessments need to start earlier. I think assessments for psychological state needs to be done when the patient comes in, and periodic assessments just to make sure the person is asked about mood, asked about anxiety, asked about sleep. And at the time of discharge, I think it's important to tell the patient that they might express, if they haven't already done, acknowledge the fact that they've had these symptoms. Make sure they monitor these symptoms when they go out. Make sure they're counseled about sleep hygiene and other factors to improve their sleep. Counsel them about the use of tobacco and alcohol. And more importantly, I think, tell them when they come for follow-up to let the internist know whether the person is having any of these symptoms and to reach out if they do have them. There are some very, very simple self-help measures, to kind of relax oneself. We talked about yoga earlier, making sure that they do something to kind of improve their mental well-being, some degree of self-monitoring of mood. I think these are very important, and to make sure that they are provided some social support when they go back, so there is no sense of serious isolation. If they're, of course, on medication, to warn them about the psychiatric side effects of these medications. I think those are important strategies at the time of discharge of the patient.
Thank you very much. I think that's been very informative. I have a question now for Ambuj, and this question says, and this is something that we've covered in the past also, but since it's come up, I'll ask this again. In a patient who comes with acute MI and is COVID positive, what interventions would you consider? And how would you manage sinus bradycardia as a complication of COVID-19? We presented a case in one of our grand rounds, if I'm not mistaken. Yeah.
So, as for the management of acute MI in a patient in the environment that we are, it has to be kind of individualized based on your hospital policies and infrastructure and readiness to handle these patients. So, ideally, yes, all acute STEMI cases, ST elevation MIs, should undergo primary PCI, but it may always not be feasible, because of the very infrastructure needed and the lot of PP that is needed, because it may not be immediately possible to test them. And in a STEMI situation, you can't wait because every minute lost is myocardium lost. So you need to be very quick. So if there is a delay because of testing or anything of that sort, or getting the lab ready in terms of personal protection, then I would say go ahead and thrombolyze him and do what we call a pharmacoinvasive strategy. And by that time, if you can get a quick test, like what we're doing is doing a CBNAT, and we get a test report in 3 to 4 hours, and then we do the invasive part. So you could either do primary PCI if your setting allows, or you could do pharmacoinvasive strategy, which is fairly good in terms of outcomes as compared to primary PCI. So those are the ways, but again, so it has to be individualized. It has to depend on the resources and the center that you work on. Coming to the question of bradycardia, this was exactly the case we presented. Yes, there are reports of bradycardia associated with COVID-19 infections. We know heart and the conduction system has plentiful of ACE2 receptors, which the virus binds to, and therefore can lead to these conduction abnormalities. So bradycardias have been reported, and we presented the case of a patient who had severe sinus bradycardia and just required initial support with medications, and she spontaneously recovered and did not require a permanent pacemaker subsequently. So yes, that may happen, and that's well reported. In fact, other arrhythmias like atrial fibrillation, frequent supraventricular ectopics, even ventricular ectopics have been reported in association with COVID-19. So yes, rhythm abnormalities may happen, and we'll again have to individualize the management. And what is important to know that these may be very transient, and we should not rush in immediately to do procedures like pacemakers. And if we can tide over this initial phase of the infection, they may kind of be self-limiting and be spontaneously improve.
Thank you, Ambuj. I have a question now for Dr. Anant Mohan, and this is basically two questions, but they're linked. One question is, how can we prevent post-COVID sequelae? And is there any role of starting early pulmonary rehabilitation, incentive spirometer, yoga, or some degree of physiotherapy while the patient is in hospital? And could that actually decrease the degree of post-COVID pulmonary fibrosis?
Yeah, so see, prevention of the fibrosis, as of now, again, we do not have a definitive answer to that. We do know that the development of fibrosis is to some extent correlating to the degree of involvement in the lungs as assessed by CT scan, that is the severity of the illness. So we can kind of predict that if there is extensive disease in the lungs, he may be more at risk for development of fibrosis, and then we can tailor-made the therapies accordingly. As far as the early rehabilitation is concerned, yes, definitely there is a role. And actually rehabilitation, pulmonary rehab should ideally start as soon as the patient is admitted actually to some extent. So what exactly to start will have to be tailor-made and individualized as for according to his abilities to do. It can be something very, very simple like just a couple of breathing exercises, breath holding exercises, simple ones. So if somebody is very hypoxic, then we really don't want to stress him out. But if somebody is just able to maintain himself, to all those patients, some degree of pulmonary rehab should be initiated at the earliest, and that should be in a graded fashion, that should be escalated. And when they go home, they should be ideally taught the methods of rehabilitation, and after that they should be monitored at home by the video conferencing and the teleconferencing to make sure that they are doing it on a regular basis. So that is the strategy which can be most cost effective, and yes, the benefits of course we'll have to see in the long term, but it does make sense to start pulmonary rehab as early as possible.
Thank you. I think this is an important thing, that if the person is able to, he's in the ICU and has some degree of respiratory or pulmonary involvement, one can start early rehabilitation. This is something that has also been seen in COPD patients, and we've also seen that yoga also helps. The randomized control trial that we did in the past in the department showed that yoga was equally effective, and therefore you don't need to have an extensive pulmonary rehab program. You can start off with yogic exercises, both as a part of rehabilitation while in hospital, and continue that after discharge, so that could also be useful. So there is a need to develop some sort of a exercise protocol for many of these patients, and as has been shown by the data which Anand presented, that many of these patients over the subsequent 4 to 6 weeks do show good recovery as far as their lung function and saturation is concerned. So now I'm going to really ask two questions to Mangla. One is regarding the is there a role of giving the newer oral anticoagulants versus low molecular heparin patients who are admitted, who are COVID patients who are admitted? Can we give the Novax in them, or should we continue with low molecular heparin? And once we are giving oral anticoagulants, is there any difference in giving rivaroxaban versus dapigatran?
So for inpatient ICU, we know that the oral, a lot of interactions going failure. We can't really predict what's going to happen. So we prefer to do low molecular weight in the ICU. On the medical floor, patients that are not as sick, the oral medications are not used with low molecular, the comfort of the patient. But in the ICU, we don't do that. Upon discharge, we are trying to use rivaroxaban. I'm not exactly sure why that one over the others. I don't have a good answer for it. One of our clinicians is on national committees on this, and this is the suggestion that they have. So we've been doing that, but I don't have a really good answer as to why. And I think you can use any of the oral agents. We do 30 days post-discharge on high-risk patients that we're giving them anticoagulation if they have no other contraindications to taking it at home. And that's what we've been doing pretty much since the very beginning of COVID. And for in-hospital patients, we're doing low molecular weight heparin twice a day instead of once a day for those patients, because we do believe that they're much higher risk for PE than other patients that we see.
Thank you. This is one question that I have for Anand, which is that in patients who are giving high FiO2 using HFNC, could that be a risk factor because of oxygen toxicity for increasing lung fibrosis? It's an interesting question, so your comments on that.
Yeah, so I think as of now we are using more and more high flow nasal oxygen now, because just like we were discussing, to try and avoid intubation. So as of now, we have found more benefits. We are yet to look at the long-term side effects of this on a physiological basis. So again, that will have to be seen as how it affects the fibrosis. Of course, the patients who are on HFNC are likely to be those who are having more extensive lung damage. So unfortunately, we are not really doing CT scan in most of our patients in the hospital because of logistic reasons, at least not us. I'm sure many others in other hospitals would be doing depending upon their facility. Unless we are doing regular CT, then maybe we can compare that later, that these were the patients who got HFNC, they had baseline this level of the lung damage, and then that went on to develop fibrosis over the period of time. So that correlation will have to come when we follow up a cohort over a period of time, I would say. So again, we'll need some time to answer that one.
Mangla, any comments from your side as far as this oxygen toxicity with high flow nasal cannula?
We have been getting ones that progress go on to having lung damage, worsening fibrosis. So we have not been doing serial CAT scans on these patients either. Sometimes they'll get a CAT scan some point in their course, but not everybody. So I don't have an answer, but we are very concerned because these patients who are on high flow are getting a lot of oxygen and are also the ones that are really using a lot of accessory muscles and creating a lot of negative pressure and positive pressure swings. So we are concerned that we're doing it. Again, we have also gone to this as our primary method of ventilation in these patients to avoid ventilators. But definitely in the back of our minds, we're concerned that we're making the problem worse. We do know that once they get intubated and develop pneumothoraces, pneumomediastinum, that their mortality rate is very high. So we agree that we're trying to prevent that as much as possible. I'm just not sure that we're not creating another problem, as you're saying. I don't think anybody knows the answer yet to this, but in this acute phase when we're all just dealing with getting through with the numbers that we're seeing, I think we have no options. But it will be an interesting thing to look at long term, looking at the patients who had early intubation versus the ones that we went on high flow and then got intubated, if they did worse from a fibrosis standpoint. I'm not sure.
I think we don't have the answer for that, but it's an interesting question. But I think currently the issue had been of acute management rather than looking at the long-term sequelae. And at that point in time, we were more concerned in saving lives and preventing secondary complications. And now we can sort of retrospectively see whether it caused any long-term sequelae. But I think it did make a huge difference in terms of decreasing mortality. So the answer may not be there right now, but maybe in the near future we'll get some answer. There's one question which I have for Dr. Ambuj, and this is regarding myocarditis. How are we treating COVID-19 myocarditis? Are we giving steroids for that? Because some people have raised in doubt that it may be harmful. And what is the long-term sequelae in terms of cardiomyopathy in them?
Yeah, so we're just learning about COVID-19 myocarditis. In fact, there was an interesting report in JAMA Cardiology of 100 patients who underwent MRI to look for this, exactly for this myocarditis. And they've found a very large, MRI is a very powerful imaging method, and it could pick up very subtle subclinical changes. And they found that almost 75%, 78% of the patients had some change in the T1, T2 native imaging, and almost 60% had ongoing myocardial inflammation, and the ejection fractions was mildly lowered in them as compared to the age-matched and risk-matched controls. So a bit of an alarming study, but what its long-term complications or what its long-term outcomes will be in terms of cardiovascular outcome on the heart is not known. This is just one-off study. We are also doing an assessment of post-COVID patients with cardiac MRI, and more such data will help us understand this disease. I would, and very early my cardiac involvement, like what has been reported in that study, not recommend steroids because these patients did not have clinical heart failure. But I think this is again an evolving field, and we'll learn as we go. So very limited. So the steroids would use or not using it would really be determined by the primary pulmonary condition rather than a cardiac condition. But yes, these have to be kept in mind that COVID can lead to cardiovascular events, especially in prone patients who have heart failure or patients who have established cardiovascular disease.
Thank you. We're almost coming to the end of our grand round. So just a few questions I'll ask. We have a bunch of questions, but I don't think we'll be able to answer all of them in the time that we have. But to Saurabh, there are two questions which I'll club. One is regarding the post-COVID chronic cough. How are we managing that? And the other is, how are you managing post-COVID myalgias, which a lot of the patients are, one doctor is seeing a lot of patients with these complaints.
So regarding the chronic cough, we have been prescribing a lot of inhaled steroids for these patients. The patients who are coming to our follow-up for post-COVID cough, so probably it has helped them to some extent, and we have been using cough suppressants, also syrups, but predominantly the inhaled steroids and the cough suppressants are the ones which we are using. We still don't know the efficacy and how long they will be helping these patients. The second question was on myalgias. So if we see, myalgias are very, very common. And the major problem with most of these patients who are being discharged from hospitals are that most of these are actually not advised any mobilization or any physical activity. Once they go home, a lot of them are bed bound on oxygen. So one important thing is that any physical activity will gradually lead to improvement in these myalgias. But over the next few weeks, like 4 to 6 weeks, myalgias improve. We do give them vitamin D and calcium supplementation, which is like vitamin D deficiency is a epidemic in our country, but the management of myalgias is probably gradual recovery from the illness and the mobilization of these patients. The problem which I would say we are also facing is that reopening the rehabilitation services, like formal pulmonary rehabilitation programs in the country are still closed because of the pandemic which is going on. So like teleconsultation based rehabilitation or telephonic follow-ups and advising them would help in regaining the muscle power and reduction of myalgias.
Thank you. I'll just take up two questions and then I'll ask all the panelists to give their final closing remarks and anything that they'd like to say as take-home messages. The two questions which I'll probably try and answer are, one is regarding the use of plasma and tocilizumab. The question on plasma has come up because of the recent study which has been released by ICMR, which did not show any benefit as far as plasma were concerned in mortality or the disease severity. I think it's important to remember that this was a real life data which they looked at, and in many centers, because they could not do the antibody titers, plasma was given without looking at the antibody titers. And we know now that even patients who have, even if you take convalescent plasma for patients who have recovered, they may not have enough neutralizing antibodies to really be labeled as convalescent plasma, and that's why it's important to do that. Also, it's important when you give the plasma. The study which came from Erasmus University actually showed that if you gave it late, and they actually looked at the antibody titer in the patients and found very high antibody titer was already present in these patients when they were planning to give them plasma, thereby stopping the study because it didn't make sense in giving plasma when the antibody titer in the recipient was already very high. The role of tocilizumab, because of the fact that Roche has withdrawn it, or the study, the COVETA trial, did not show it to be useful. There are data both ways. There are studies in the Lancet Rheumatology which has shown it to have some mortality benefit also. The initial studies also showed it was of some benefit. I think tocilizumab does have a place, but it has to be used very selectively in those individuals who, despite getting steroids and having definite evidence of worsening with cytokine storm, are needing it. It's not something that can be used for all individuals. The other question is that if you have a high CT score at the time of discharge, should you start steroids and antifibrotics? I think you will have to again look at what we discussed. If you have features of which suggest that there is some degree of lung fibrosis, irrespective of the CT score, you should consider steroids, but really there is no role of starting antifibrotics upfront. Thank you very much to all the panelists for their very, very good comments, and I think clearing the doubts and answering the questions which came up through the WhatsApp. I'll start by asking for the final comments from people who are on our web link. So I'll ask Dr. Pratima Murthy to give her comments first, and what she would like to really give a brief take-home message.
Thank you, sir. I think the first thing I'd like to say is that in some ways, COVID has brought mental health to the forefront. It's not just called a COVID pandemic, but also a mental health pandemic. We've known that mental health problems have been there in different phases. In the lead up, leading to almost preparedness fatigue in the initial part, a variety of psychological responses in terms of stress, in terms of anxiety, in terms of depression, sleep disturbances, and the use of substances. And of course, with COVID infection, I think it's very, very important to recognize that there can be psychological reactions to the physical illness. There can be neuropsychiatric complications as a result of COVID, both due to the neuroinfection and due to neuroinflammatory responses. There can be important decisions in persons with mental illness in terms of the use of psychotropic medication, the psychological or psychiatric side effects of the medications used in a COVID-19 treatment, and the interaction of these. The most important thing is that patients need to be psychologically supported during their infection, and of course, post-infective sequelae are also recognized, and we need to recognize that. Finally, I'd like to say that a majority of people, as we all know, do recover uneventfully from COVID, and I think that message is something that we need to, give everybody, and of course, support them in mental wellness.
Thank you very much. I think it's important to give this message that you do recover from COVID and you can recover and come back to normal. This is a very important message because there's still a lot of fear and stigma as far as COVID is concerned. Your final message and comments, Mangla?
Is learning every day from this, not to keep a closed mind as to treatment options and to keep looking out for new sequelae that we didn't see before, that we didn't understand. I think we're seeing a lot of young, very sick patients that we're going to be dealing with for many years to come with their COVID sequelae. So I think it's going to be a different world for pulmonary medicine and for hospital medicine with all of these new patients and the percentage of people that have been affected by this. We may have to reframe our thinking about transplant and other things in the future as we are dealing with this population that will continue to be chronically ill going forward. So I think a lot to learn, and hopefully we'll all look at our experiences and be able to take something from it. Thank you. Thank you for having me.
Thank you, Mangla. Thank you for joining in, especially early in the morning. I think it's around 7 a.m. as far as New York is concerned. So you've gotten up early. Thank you very much. And as always, a pleasure to have you. Thank you very much.
Same here.
I'll start with now the panelist here and with Dr. Saurabh for his final take-home comments.
So probably the major problem which we are facing after COVID is the myalgias, and the patients who are requiring oxygen are not being advised for mobilization and physical activity, because that physical activity improves their physical well-being, reduces the oxygen requirement, as well as reduces the mental stress. So this mobilization after discharge is essential component for a post-COVID care.
Thank you very much for your comments.
Yeah, thank you, sir. So I would just say that without being alarmist, is that potentially COVID-19 can leave a trail of lingering health problems beyond the pulmonary system. And I would say that we should be on vigil, especially in patients who are high risk for cardiovascular events, because that is something that can still happen after a successful treatment of COVID-19. So we should not neglect the non-COVID part of the patient's health, and probably in patients who are, especially patients who have cardiac ailments, they should consult or teleconsult with their cardiac physician or cardiologist and try to recalibrate their medications to provide maximum cardiovascular protection against these diseases.
Thank you very much, Dr. Anand, for your comments.
Yeah, sir, just conclusion is the same as I just wrote in the slides, basically that one is aware now that COVID is becoming a kind of a multidisciplinary kind of a illness, and we know all organs are involved, so many organs. over a period of time, we are likely to see the complications in many of these organs. So all the related specialties, internists and all the allied specialties, when they see those complications, they must be kind of aware. So clinical suspicion will have to be seen, and the important thing will be to try and prevent that. So I think our focus will have to be on prevention. Now that we know complication occurs, the next step is to try and prevent them. So that is the way forward, I would say. Now that we know the problem, we'll have to find out how to prevent the problem. One of them would be, of course, early institution of rehabilitation, mobilization of any way, whether it is good nutritional, psychosocial support. So all these things together will have to come together now in one way or the other. Before a person is discharged, all of these things should be initiated. That is what I feel.
Thank you very much. I think we've had very important messages, and I think it's important to remember that care of COVID patient doesn't finish once they're discharged. There is a lot of that we're learning now as far as post-COVID sequelae is concerned, and this is something that we need to address as we go forward from the pandemic and for many years to come. So when we start looking at post-COVID sequelae, we have to look at it holistically. As Anand mentioned, it can involve various organs. It can be a simple thing like body aches, myalgia for post-COVID fatigue, but it can also be something very serious like extensive lung fibrosis or extensive cardiac involvement. So there is therefore a need to evaluate our patients not only at the time of discharge, but for follow-up. And therefore there is a need now to seriously think of having post-COVID clinics in various hospitals, especially tertiary care hospitals, where we can evaluate these patients comprehensively, whether it be related to mental health, the psychological stress that they have, the lung function or lung capacity, or various other organ involvement. So I think the future is that we will need to look at management strategies of post-COVID sequelae. And as was mentioned, we should still work on trying to prevent them as much as possible. So once again, thank you very much for joining to this combined round. On behalf of the entire faculty and the entire team at the All Indian Institute of Medical Sciences, would like to really thank you all for joining in, and thank the entire team, especially those behind the scene who really work very hard to get this grand round on time and online and without any glitches. So thanks to everyone, and hope to see you again with another topic next week. Thank you very much.